Good morning, everyone. This panel will deal with innovations in healthcare access and delivery, and that's a broad term for a rather diverse group of presentations that you're going to be hearing from our panelists, our distinguished panelists. I'd like to tell you who they are. I'm just going to give their names and titles, that you can read more about them and their bios that are in your journal. The first, there's Dr. Michael Barr, who's Executive Vice President of the National Committee for Quality Assurance. That's NCQA. I think you all know what that is, here in Washington. Following him, we have Dr. David Ricks, or David Ricks, M.B.A., who's the president of Lilly Biomedical, Eli Lilly and Company in Indianapolis, Indiana. Following, Dr. Wayne J. Riley, president of the American College of Physicians in Philadelphia. And finally, next, Michael Ybarra, who is the Senior Director, Alliance Development, Pharmaceutical Research, and Manufacturers of America, in other words, PhRMA, from Washington, D.C. And finally, we have Aaron Vandervelde, M.B.A., who's Managing Director of the Berkeley Research Group in Washington, D.C. Please give us a welcoming applause for our distinguished panel. Before we get started with Dr. Barr, I just want to make a couple brief remarks so that we give the maximum time to our panelists, who won't have much time individually. We're going to be moving with the speed of light. In any event, this issue of healthcare access and delivery is something that can be looked at in various ways. I must say that I had the opportunity to take an in-depth look at this topic starting a few years ago, and developed a book which was published in 2011 called Healthcare Disparities at the Crossroads with Healthcare Reform, published by Springer, and it covered several aspects of access to health care, especially for minorities, and particularly for blacks. The reason that I mention this is that in the book, I made a statement which I think has to do with some of the things that we're going to be covering today, no matter whether we talk about 340B or pharmaceutical industry and issues there, or whether we're talking about particular access to health care and delivery problems and innovations that we can make in the system. I mentioned in reference to some of the measures that are being developed in regards to health care reform issues, that there are some myths which I wanted to try to dispel. And one thing was that I talked about insurance coverage, which some people may be covering on this panel. And I mentioned that it was widely believed that the possession of insurance coverage would provide greater access to care and would magically create health equity, which is something that we all seek, of course, and that disparities would no longer exist. So this is something that many people felt, in other words, that once we had either universal or near universal health care coverage, that all of our problems would melt away. But nothing could be farther from the truth. The establishment of health care reform, with its major ingredient, near health care universal insurance coverage, is exactly the best opportunity for eliminating disparities. And I mentioned that there must be a well-funded activist effort to connect these two entities, that is, healthcare disparities elimination and healthcare reform. Well, we're going to be talking about some innovations in regards to trying to do exactly that. That is, to create greater access for minority patients and particularly African Americans, and also to develop new innovative methods for healthcare delivery. So let me begin with bringing to the podium our first panelist, who is Dr. Michael Barr. As I mentioned, he's the Executive Vice President for NCQA, and Dr. Barr will give us his wisdom in regards to innovations in healthcare access. Thank you.
Thank you, Dr. Williams. Good almost afternoon. Question for you. How many of you have taught a teenager how to drive? Congratulations, you survived. My 16-year-old son just got his permit. Remember the early days? Get in the car, put on your seatbelt, adjust the mirrors, step on the brake, turn the key, or now, of course, push the button. Check your surroundings, put the car into drive, and now I say my prayers. Now, what if we judge success based on completing all of those preparatory steps instead of how he drives through the neighborhood safely? There's certainly important steps, probably evidence-based. I wouldn't want my son to learn to drive without routinely doing them, but is that really the way in which we should assess his success and the quality of his driving skills? This is the challenge we face in the quality measurement arena. Structure and process measures are very important, and doing the right thing routinely is a fundamental aspect of improving quality. However, most of the time, these steps do not get us to our destination. They do not add up to the success we want to achieve in caring for people. So NCQA is a not-for-profit organization focused on healthcare improvement through measurement, transparency, and accountability. And I want to share with you some of the ways in which we are working to address the need for better outcomes, measures, and stimulate innovation in healthcare access and delivery. Most of you have probably heard about HEDIS, the Healthcare Effectiveness Data and Information Set. HEDIS is the way NCQA evaluates health plans and evidence-based quality measures for over 70 aspects of care, and 172 million Americans, over 50% of the US population, have health plans that report HEDIS results. The methodology and process of collecting data in support of HEDIS measures have evolved over the years, but to be honest, they still depend predominantly upon claims and a labor-intensive chart review process. Now, we expect that to change because the foundation to access clinical information in support of better measures is being built. Over the past 5 to 6 years, the Centers for Medicare and Medicaid Services EHR Incentive Program, also known as Meaningful Use, has encouraged the widespread adoption and implementation of electronic health records. By some accounts, over 90% of internists and family physicians have certified electronic technology in their offices. Now, even with all the challenges and concerns about usability, workflow, and interoperability, this is still a major step in the right direction. The technology should improve over time as we shift from implementation to optimization for care. Now, to demonstrate improvement in care, we need to be able to measure it at the practice level, accountable care entity level, hospital and plan levels. And to do that, we need the appropriate measures. There are several desirable attributes that fall into about 4 categories. Relevance. Is the information captured important to consumers, purchasers, clinicians, and healthcare systems? Does it address an important feature of healthcare that will inform choices? Will the measures stimulate quality improvement? The second is scientific soundness. Is the clinical evidence robust? What guidelines have been published? Is there a link between processes and outcomes? Does the measure make sense logically and clinically? Does it precisely evaluate what it was intended to evaluate? And is it appropriate to stratify based on age, sociodemic factors, or other types of features? And the next one is feasibility. Are the specifications reasonable? Do the data exist? Are the sources available and accessible? Is there a significant burden associated with collecting and reporting the measures? And the final one is actionable. Will the measure really stimulate change? With this brief background, let me introduce 3 approaches to motivate delivery system innovation and improvement in health that NCQA is exploring. The first is, it's the quality of the quality measures that counts, not the quantity. The second, measures should let stakeholders make comparisons across programs. And the third is we should identify and implement measures that address the unique needs of individuals. So I'll take those each in turn. It's the quality of the quality measures that counts, and not the quantity. No one advocates for the proliferation of unnecessary, redundant, or meaningless measures. But periodically, concerns are raised about the number of measures, and then an effort ensues to try and streamline them. In 2005, the Ambulatory Care Quality Alliance identified 26 measures for primary care. And then in April of 2015, the Institute of Medicine released the Vital Signs Report, which also narrowed down to 15 buckets of categories. And then just recently, a couple of weeks ago, America's Health Insurance Plans led a collaborative with CMS, health plans, professional societies, and other stakeholders, and they identified a core set of 22 measures for patient-centered medical homes and accountable care organizations, and another set for other types of specialties. Now, these are all important efforts, but you can make a case that we might benefit from more measures to address gaps in care not assessed by the current measurement sets, as long as they meet the criteria I referenced, and are not dependent upon documentation or work unrelated to actually improving care. That is, they should not distract overtasked clinical teams to do additional work just for the sake of documentation to support a particular measure. The measure should generate results that are relevant and actionable, but not require expensive interfaces or a computer science engineer to implement. All right, the second one is measures should let stakeholders make comparisons across programs. In order for any valid comparisons to be made across programs, such as the accountable care organizations, medical homes, the new merit-based incentive program system that's coming out through macro or alternative payment models, measures need to be specified appropriately for each situation, yet aligned in concept and intent. For example, aligned measures would help ensure that if I take care of a patient with diabetes in the practice and I'm improving my diabetes metrics, that the health plan for that patient also sees a concomitant improvement in their HEDIS scores. Measures should be judged on their ability to do exactly that, to align across different domains. And the third is identify and implement measures that address the unique needs of individuals. What if we shift our focus to overall quality of life rather than improvement in structure and processes or laboratory values? We would take into account a person's desired goals, perhaps decrease symptoms, reduce the risk of harmful events, maintain or improve functioning, or goals such as reaching an important life cycle event, a wedding, an anniversary, a birth. What if we could take readily available biometric data such as body mass index, blood pressure, cholesterol, smoking status, and get an individualized score that then becomes the subject of discussion between a person and his or her clinician to help craft an improvement plan by modeling the influence of different choices. Should I quit smoking? Should I lose weight? Should I exercise? You can't do everything. Which one of these is giving me the best benefit? What if we took patient-generated information and then incorporated it routinely into care plans we develop with people and their families? What if we accepted, I'm talking specifically about NCQA, what if we accepted valid auditable data wherever it is stored, the practice, the health plan, the accountable care organization, the health information exchange, and use it to assess quality? Now, some of you may recognize the references I just cited to goal-oriented measures, patient-reported outcome measures, and the Archimedes model for assessing global cardiovascular risk. NCQA is working in all of these areas, as well as launching what we refer to as Electronic Clinical Data Systems Initiative. That is the opportunity to pull information and data that we can retrieve to support quality measures and improvement over time. And we are working, the first step is we're working with 14 health plans right now to assess 3 different depression measures that will assess outcomes over time using data that we can pull from all these different systems instead of the traditional method. Now, we know there are considerable research and implementation testing ahead of us. However, we believe these principles and the innovations in measure development, implementation, and use will enhance quality outcomes, provide more transparency, facilitate greater accountability, and drive delivery system change. In particular, with the growing interest in the patient-centered medical home, the patient-centered specialty practices, both of which are referenced in the Medicare Access and CHIP Reauthorization Act, also known as MACRA, and accountability models such as the accountable care organizations and new payment models, we need better measures to ensure access, avoidance of both over and under treatment, appropriateness, and diagnostic accuracy. We can and will move past checking our seatbelts and adjusting our mirrors. Thank you very much.
Thank you, Dr. Barr. And we'll try to have a little time preserved at the end for questions and answers, Q&A. Our next presenter is David Ricks, M.B.A., who's president of Lilly Biomedical, Eli Lilly and Company. Mr. Ricks.
Thank you. It's an honor and pleasure to be here. I appreciate the invitation, and I have the non-controversial topic of talking about value for innovation or drug pricing as we know it. And I don't take that lightly. I'm speaking to a group of physicians who I know every day, I think see both ends of this debate, that we live in an era where medicines are making a profound difference for your patients. Just think in the last 2-3 decades, we've taken HIV/AIDS and turned it into a chronic manageable disease. Every year for the past decade, the rate of major cardiovascular events, hospital admissions due to them, has fallen. That despite the fact that I don't think we're living a healthier lifestyle, but medicines are making a big difference. We've taken cancer and turned it in many cases, to a chronic manageable disease. All this through the power of innovation in medicines, and I think you see that in your practice. On the other hand, every day, I'm sure you talk to patients who are struggling to find a way to pay for the medicines that you're prescribing. And what I would like to assert, if we can have the slides now. Do we have slides? There we go. Ordering them up now. What I'd like to assert is that both of these things are in fact true. That we have tremendous opportunity for innovation, and this continues due to the biomedical revolution, genomics, et cetera, to really create life-altering disease medicines. And on the other hand, it's very expensive. And we need to think about new ways to pay for and help patients pay for these life-changing medicines. I think at the heart of this debate are two arguments. One, do we need more regulation? Do we need more government intervention to make it affordable? And I think the advocates for that don't worry so much about where this innovation comes from, which is mostly the private sector, and the promise of a reward for pursuing that innovation. And what I'll argue today is a different view, that we need new regulation, not unregulation, but we have a market-based system that isn't working well for patients today. And it's not working well because the system was developed over the last 5 decades, and many of these well-intended policies are now outmoded based on the innovation we have. So just a little bit of context and facts, because there's a lot of publications and press clippings on drug prices, but just to put it in perspective, this is data from CMS, from the federal government, who's been tracking the components of healthcare costs in the country since the mid-'60s. And essentially, if you look at those components, which are listed here, drugs, hospital care, physician services, home health care and nursing homes, administrative costs, and then other, which is primarily devices and dental, these allocation of spending in the U.S. healthcare system is almost identical over the last 5 decades. Today, we spend about 10 cents out of every healthcare dollar on prescription medicines that are over the counter or at the pharmacy counter, and another 2 or 3 cents in hospital or physician-administered medicines, and that rate has basically been static for the last 50 years. I think people who want to talk about drug pricing in a negative way would lead you to believe that this has been growing dramatically, but the fact is healthcare costs are growing, and drug pricing are growing with them, or drug costs are growing with them, but not in a disproportionate way. One of the reasons I think people feel like pharmaceutical pricing is escalating at a more rapid rate is how our insurance industry and our federal programs, state programs, administer cost of drugs. Of course, it's reasonable to ask patients to pay for part of their own health care. But the rate at which we ask them to pay for their medicines versus all other components, I would argue, is skewed and out of date. Today, patients on average pay about 20% of the absolute cost of their medicines, while only 5% of hospital care. The largest contributor to healthcare cost is hospital care. Why is it that we have a system that biases against technology that can allow you to treat and live with your disease without using a hospital system versus going to the hospital directly? I think this is something we need to talk about and potentially reform. Now, there's a lot of discussion about drug pricing. People publish reports, even CMS has a report. A lot of this is based on list pricing, and one of the things I want to debunk today is list pricing has almost nothing to do with the amount of revenue our company captures from selling a medicine. It is in many ways as artificial as this price on the back of a hotel room door I stayed in recently. I did not pay $3.99 a night to stay in this hotel. It was much, much less. These are prices for indexing purposes primarily. Very few people actually pay them. If we look at the components of our healthcare system, we basically in the U.S. have 4 different methods by which we deliver drugs to patients, and they get paid for. Of course, Medicaid, which is a grant system for states for indigent patients, many of which probably you see, has very specific rules for drug pricing that are very difficult economics, actually, for our industry. An interesting fact is, for most of our medicines on a global basis, the lowest price that we can charge in the world is U.S. to U.S. states. An extreme example is insulin, where our company helped commercialize insulin in 1923 and has been serving diabetes patients for many, many years. The price we charge to 50 U.S. states for a vial of insulin is 0 by statute. We lose money on every prescription you write in the Medicaid system for insulin. We need to participate in that to participate in other federal programs. It's a big subsidy to states and obviously an indigent population, but we don't make any money in this category. In Part D, we have a system where the federal government employs third-party actors to negotiate with drug companies. This is a hot topic here in Washington, whether that system's working well enough for our budget at the federal level. I would just point out that this is one of the most successful programs that has been observed in terms of exceeding the savings expected. When we look at the Part D system today as a manufacturer, I'm selling to very well-organized and concentrated buyers who exact a very significant discount for our products. Part B is, of course, the federal program as part of Medicare. This works in a very different way for physician-administered drugs. And this is a system that was built long before we had so many physician-administered drugs that could change lives. Probably is in need for more discussion. And then, of course, commercial markets, which I'll touch on in a second, but also do an excellent job in negotiating discounts from manufacturers. The reason for that is, and this is a chart that shows the pharmaceutical benefit companies in the U.S., and when I joined this industry 20 years ago, we had about 250 what we called national accounts or large buyers of our products. Today, there are essentially 6. So like anything, if you're a seller and you're selling to only a few purchasers, we become a market taker, not a market maker. These companies like Express Scripts, CVS, Caremark, et cetera, do quite well in negotiations with all pharmaceutical manufacturers, and year over year doing better and better. Most of our arrangements with these manufacturers have price increase caps, so they experience no price increase. Each year they compete categories and exclude innovative medicines from their formularies, even though that may be a choice you would like to make for your patient. So this is a highly competitive and tough market for us. Has nothing to do with list pricing. None of these entities pay a list price. If we look at another way to look at price is through a long period of time, and some critics assert that drugs are one of the few categories of consumer goods where the prices always go up. And I will admit that list prices do rise during a patented period, which is a government-granted monopoly for our innovation. But if we look at the long haul, over decades, one of the legacies of our industry is we create a large pool of effective and affordable medicines via the generic market. Generics don't come from companies in India or in overseas manufacturers who offer them cheaply to your patients. Yes, they make them, but those inventions exist because of innovative pharmaceutical companies. This is a look at the average cost of the top 10 therapeutic categories paid for by Part D. This is actual government data and forward projections from the Congressional Budget Office. And as you can see, year over year, these costs are declining. While the individual medicines that are branded may be rising, that's offset by massively increasing generic utilization and a very, very competitive and healthy market for generics in the United States. Many of our inventions are now available for literally pennies a day that can change the lives of patients. That's a legacy of our industry and one that I think needs to contribute to this drug pricing debate. Now, patients should pay a part of their healthcare costs, we would assert, but how much? And I think one of the things that's broken in today's system is what our insurance industry is paying for as a percent of the total cost of medicines. This is a chart that's developed by a third party asking patients with these conditions what they think they should pay per month out of pocket for their medicines. And these are some significant numbers. I think patients want to get better with these conditions, and it also gives you an idea of how these patient groups feel about how compelling the innovation might be for their condition. But unfortunately, in most health plans, and most recently I think in the exchange system, we're seeing patients pay significantly more than these amounts, and a patient's left with a choice of not having their medicine or paying more than they're willing or able to. This is a topic we need to engage in, and I think a change that needs to be made.
That's per year or is that per month, that cost?
This is per month maximum out of pocket that they're willing to
Per
pay.
month.
Yep. So the drug industry, the pharmaceutical industry, has a key role in this discussion, and our company believes that. We need to help patients bridge the gap in the insurance system that exists today, and we in fact do that. Today, our company has a number of programs to help patients who can't afford to pay for their medicines. I interestingly noted on the back of your program brochure is one of them, in case you want to know how to tap into that as a physician, called Really True Assist. This is actually, it's a philanthropic program where we have free goods available to patients who need medicines. Last year, that was $500 million in subsidy we provided. Additionally, we provide copay cards to help patients who have insurance bridge the gaps in their insurance. This is last year over $60 million and growing almost 2x year over year because of the way the health system is working. We also need to play a role in being for something, not just against change, but for changes. I co-authored a health policy or health affairs op-ed last month with my colleague at Anthem Health on some of the solutions we need to pursue to change the regulatory environment we have to let the market work better for innovation and for your patients. And look forward to engaging in that. And finally, to the speaker to my right's comments, we need to stand behind the value of our products and the innovation we provide, not by talking about the input costs, but by talking about the outcomes, value that they produce with the massive digitization of health records, with our ability to analyze data through time. We have an obligation as manufacturers to publish that, to make that available for your decision-making when you treat a patient. Thanks for your time, and it was a pleasure to join you today.
Thank you. Oh, sound here. Okay. Thank you, Mr. Ricks. When Dr. Ybarra comes up, I wondered if you could make some comments in regards to whether the innovations that were mentioned by Mr. Ricks could or are extended throughout pharma. Okay, I think that'd be very important for us to know. Our next presenter is Dr. Wayne J. Riley, who's president of the ACP, and you should read his bio, which is in your journal. Dr. Riley.
I'm going to stand. That's the professor in me. Good morning, good afternoon. Delighted to be here. I have the wonderful honor of leading the 143,000-member American College of Physicians. I'm only the third African-American president in our 100-year history to occupy this office. And I know it was the NMA that made it possible many years ago for African-American physicians to ascend to the presidency and leadership of the bigger medical organization. So I take this responsibility very seriously. In terms of innovation in healthcare and access, I think Dr. Williams hit the nail on the head. The president was in Milwaukee Friday, and he was trumpeting the fact that 20 million people have gained insurance under the Affordable Care Act, which is a tremendous achievement. And as I travel around the country, I travel to both red states, purple states, blue states, and everything in between. You do see begrudging acknowledgement that access to health insurance, whether it be Medicaid expansion or through the exchanges, state or federal, has made a big difference in the health of Americans. But we know that that's not the entire story. And as Paul Harvey used to say, the rest of the story is that we have to deal with the copay issue, the restrictive network issue, which I think African American physicians in particularly in particular, have been a little struggling with in terms of the restrictive networks. And that's an access choke point that needs to be appreciated as we work through the early years of the Affordable Care Act. Now, for those who say that the Affordable Care Act should be perfect on day one or year two, that's unrealistic. We've been refining Medicare since President Johnson signed it at the Truman Library. And no one will say that Medicare is an ineffective program. And so that's the spirit in which we ought to look at the Affordable Care Act. Now, in terms of innovations beyond the Affordable Care Act, I thought that these were the ones that I would like to raise with you, my African American physician colleagues, because I see this as particularly important for access for the communities we serve going forward over the rest of our professional lifetimes. First, precision medicine. The promise, and I refer to the peril of precision medicine. President Obama has put out a bold initiative to penetrate precision medicine more deeply into the American healthcare system. So what that means, colleagues, is will the patients you care for in the communities you serve have access to precision medicine tools, analysis, and so forth? Will you benefit by the information provided by a precision medicine profile? Will precision medicine exacerbate healthcare disparities or access issues? I have real concerns about that. So you can see that how an innovation has tremendous promise, but it also has some peril. Secondly, value-based payments. I see this as so significant for the House of African American Medicine. It reminds me of the late 80s and 90s when the NMA and the NMA membership was struggling with managed care. Value-based payment is here, colleagues, and I'm going to talk about that a little deeply in a second on another slide. But it's critically important that African American physicians not be caught flat-footed in the implementation of value-based payment. You can curse the darkness all you want, it ain't going to change. And so we have to embrace the movement to value-based payments. My good friend Mike Barr has already talked about performance measurement. I tell young medical students that your patients will know more about you than your mother and father. They will be able to Google how well you keep your A1Cs within range on your diabetic patients. They will be able to see if your heart failure patients have had admissions or exacerbations. So performance measurement is here to stay. We have to embrace this. And we have to tap into that competitive nature that we all have as physicians to make sure our numbers are as good as possible. Now, Mike hinted at this. Some measures are bad, and we at the American College of Physicians have been very assertive about pushing back on measures that we don't think have any bearing on the true value of healthcare, and for those measures that may disadvantage physicians like many of you in this room who take care of very challenging patients with very complicated social determinants. So again, performance measurement is something, an innovation that bears watching and vigilance going forward. Retail clinics. I learned my lesson, my own mother, the widow of a physician, daughter-in-law physician, one night sitting at dinner just casually said, "Oh, I strolled into CVS to get my shot, and I almost choked on my peas." And I said, "Well, Ma, why didn't you call me?" She said, "Why would I call you or my wife?" My wife's an internist on the faculty of Vanderbilt. "You know, I would be held on the phone for an hour. The nurse would take 3 hours to call me back. And, you know, all I wanted, you know, I just strolled into CVS. I needed some nail polish and, you know, and I got my Pneumovax."
They probably gave a discount too.
Exactly. So again, this is another innovation, colleagues, that we put out policy at the American College of Physicians. Retail clinics are here to stay. Your patients like them. Your mothers like them, your colleagues like them. But what we've said is that retail clinics should have an established relationship with specialists and primary care physicians and health systems for the referrals. Retail clinics are not the appropriate platform for chronic disease management. If you have 2 or 3 morbidities, you really need to have a relationship with a primary care physician. Our study indicates that 44% of the patients who walk into a CVS clinic or Minute Clinic or any retail health clinic lacks a regular primary care relationship. So again, that's an opportunity for the NMA membership to get those patients. It's okay if they go on the weekend or when you're out of town just for a quick thing, but for more rigorous health maintenance issues, they need to see you. And this is the point that you should underscore. Don't throw water on retail clinics. Embrace them as adjunctive to the work that you do to take care of them. Direct contracting. We looked at this. This is a trend where it's called concierge practice in some places, where physicians will take on care of patients for a defined period of time for a fee. We had some real concerns as to whether this would exacerbate healthcare disparities. Well, it can, and it may not. What we have said in our policy is that concierge practice is perfectly ethical if you get into a relationship with a patient in that scheme. But as you do, you still have a societal obligation as a physician to take care of the indigent, to teach, and to serve your community. So again, this may not be the cup of tea for many NMA members, but I would urge NMA members to look at this. We need to be able to participate in the wide variety of practice settings that our system allows. Team-based care. You know, no longer do you hear that physicians are the captain of the ship. Nope. You can't even have that mindset in healthcare today. It's too team-based, and you have to embrace teamwork. Again, an innovation that I think that members of the NMA and the African American medical community and all physicians should embrace with gusto. Finally, digital health. Your patients want access to you on their smartphones. They want their lab results without having to call your office. They don't want faxed results anymore. So again, you have to embrace technology as an innovation to make you a more effective physician in this era of healthcare reform. So in sum total, there are great innovations, but innovations have potentially untoward effects that all of us in the House of Medicine should be vigilant about, but particularly those of us who care for the communities which we do and the patients that we've always taken care of as African American physicians. Thank you.
Thank you, Dr. Riley. When we get to our Q&A, I'd like to ask in particular for Dr. Riley to address some questions regarding P4P and also EHR and some controversial aspects of that, especially as regards African American physicians. Our next presenter is Dr. Michael Ybarra, who is the Senior Director, Alliance Development for Pharma in Washington. And remember that I asked Dr. Ybarra to perhaps pay particular attention to the question of whether the things that were mentioned by Mr. Ricks, David Ricks, from Lilly, as to whether the innovations that were mentioned by him are seen with other pharmaceutical manufacturing companies within pharma.
Yeah, absolutely.
Okay? Dr. Ybarra.
Thank you. Thank you. Thank you very much for the invitation. Happy to address that question right off the bat. And wanted to thank Dr. Mitchell for inviting industry to give perspective, because obviously it's really, there are significant questions right now about ways that physicians and industry can partner, how we can work better to help patients. My background is I'm an emergency physician here in Washington, D.C. I come from the House of Medicine, and prior to joining pharma a little over a year ago was with my specialty society on the board. And it was a difficult decision, but a really exciting one, because I wanted to work with the industry and I wanted to be a partner of bridging the divide between industry and physicians, showing that we can continue to work together. And medicine is so reliant on innovative therapies. And as Mr. Rick said, really even generic therapies. I mean, it's a cornerstone of most patients' care in the primary care setting. So to answer the question right off the bat, pharma as a trade association represents the innovative biopharmaceutical companies. We have almost 50 members, or roughly 50 members. I will say we don't represent the interests of the generic manufacturers, and so the companies that probably come top of mind with some of the most recent news stories are not members of the Pharma Trade Association. And our CEO, when there was a tremendous amount of scrutiny on the price increase of a medicine to treat toxoplasmosis last year, came out publicly and said that didn't represent the values of pharma member companies, which we all agree with. That's, we really do see that there are some market failures there, and we want to work together to make sure that the market works best. As it pertains to what our members are doing and what we as a policy organization are doing, we really think about this along the lines of the way that ACP and other physician organizations like NMA are looking at value-driven healthcare, and how can our members participate in the move towards value-driven healthcare. There are ways that we can make the market work better, and there are things that can be implemented in the private sector and commercial agreements that can help. One is the use of value assessments, and just like with quality measures for drugs, there are value assessments that are good and there are value assessments that are bad. And so we as a policy organization want to play a role in the appropriate development of value assessments that take into account the value of innovation, the importance of individualized patient care. The second is our participation in the implementation of MACRA, and our policy team is very engaged in conversations with CMS, working with provider organizations such as NMA, to make sure that payment and delivery reforms take a holistic view. Innovation will play a critical role in helping patients, and we see that. As an emergency physician, when I first started my training, we admitted everybody that had a blood clot, and here comes a new class of medicines that allow us to discharge people from the emergency department. And I could see my more experienced attendings at the time who didn't practice that way. That's very, you have to introduce new therapies and it changes practice over time. And that's something that saved the healthcare system money, because we're not admitting patients. Every single patient that had a DVT, it's saving money, but there's an increased upfront cost, and it changes practice over time. The last thing is just to comment on innovative contracting. We as a policy organization are thinking about that, how manufacturers can partner with plans. And there are some regulatory barriers that stand in the way. One big one is the fact that our member companies can't talk about their products with payers before they come to market. How important is that going to be as we have new classes of personalized medicine coming down the pipeline, to be able to say ahead of time, to payers, have conversations. This is the patient population we expect. These are the anticipated diseases that it's going to be treating. It's really important that those conversations can happen, but right now there are significant regulatory barriers to having those conversations. The other is just in the realm of participation in adherence-based services. This is something I'm really interested in, because adherence is really important to making sure patients can take the medicine appropriately, that we're getting the full value of the medicine. And there are some barriers, again, to companies participating in adherence-related activities. As it relates to the implementation of the Affordable Care Act, our big platform for this is the Access to Better Coverage campaign. I encourage all of you to go to accessbettercoverage.org, because as we've all seen, our patients have insurance. That doesn't necessarily mean that they truly have access. And they may still have barriers to accessing the medicines that they need. And again, in the whole realm of making the market work better, we see plans that have placed medicines for certain diseases on the highest cost-sharing tier. So HIV/AIDS is one of the more public examples where all of the medicines, even generic medicines, were placed on Tier 4. Tier 4 is the highest cost sharing. That means the patient's going to be experiencing significant out-of-pocket costs. We see that as extremely problematic. We think that the ACA's non-discrimination, the writing about non-discrimination should apply to disease states as well, so that there is fair access to medicines in the way that plans are designing their formularies. We don't want patients to experience disproportionate cost sharing. So access better coverage. The second, in terms of making the market work better, this is a very technical program, but one that I want to just spend a few minutes talking about, because I think that this is something that we as physicians participate in. This is a program that exists because we're prescribing medicine, and yet most physicians don't know about it. And so I love to take the opportunity just to educate and welcome further conversation. And that's 340B. Mr. Ricks talked about the 4 kind of main ways of thinking about the market for medicines: Medicare Part B, Medicare Part D, Medicaid, and the commercial market. This one is somewhat cross-cutting. This is a discount that the manufacturers provide to covered entities. It was a law that was passed in 1992. It was originally a very small program with only 51 hospitals participating. And it was to provide significant discounts to hospitals and to safety net providers, certain clinics, safety net hospitals. But since the implementation, there has been a dramatic increase in the participation in 340B. We support the intent of 340B. We want to see 340B sustainable. However, a lot has happened in 30 years. As we all know, the market has changed. The access to health insurance and healthcare has changed, and so we think that the program needs to be reformed to better inline the incentives and also patients benefit from 340B. So a really brief overview of how 340B works. The manufacturer provides a statutory discount to 340B covered entities, and the example we give is hospitals, because we really do feel like, for the most part, the clinics, the community health centers that are using the program, they're a very small part of the program, and we think that they have significant oversight and they're really doing the right thing. There are some hospital arrangements that we do feel like there needs to be better oversight of, and so this example focuses on a hospital. The manufacturer provides the drug to the hospital at a discount. The hospital then provides the medicine to the patient, including patients who are insured. It's not just for uninsured patients, it's anyone that's a covered patient. The insurer then pays the hospital for the full negotiated price of the medicine, and then the hospital captures what we call the spread. So in the example of a $100 medicine where the 340B hospital paid $60, they still collect a copayment on the product, and then there's a $50 hospital revenue from it. I've heard members of Congress that used to be hospital administrators talk about this, and they said that a lot of hospitals have 340B as a line of revenue for them that they generate from the spread on medicines. And our question is, particularly in a day and age where there is a lot of attention on patients' access and their ability to pay, our patients directly benefit from this program, that our members are paying significant discounts in order to participate in the Medicare and Medicaid program. How you qualify is to receive the 340B designation through patients aren't enrolling in 340B. It's a designation provided to the hospital or clinic directly, so it's not directly tied to individual patients. Hospitals have child sites, and we've seen this happen in oncology, where they kind of buy up practices, put them under the hospital, and then they're considered a 340B covered entity as well. You're eligible for hospitals are eligible based on the DISH metric, the disproportionate share hospital, and we question whether that's the right metric, particularly since the ACA increased Medicaid expansion across the country. That we kind of question. We don't necessarily know for sure if that's the right metric, so there's some ongoing research into DISH. And then grantees are eligible based on their grant from HRSA. Most of the volume in 340B is driven by the smallest number of covered entities, and that's the DISH hospitals. We obviously all need to work with our hospitals. Hospitals play a critical role in the community. But again, in the era where things are changing in the healthcare insurance market, we need to make sure the program aligns, right, so that patients are seeking benefits. So the DISH hospitals are only 9% of covered entities, but they're over 80% of 340B purchases. Grantees are 91%. The community health centers, all of that, they're the vast majority of the brick and mortar in the program, but they represent a very small percentage of 340B. We want there to be some alignment in the amount of charity care provided. Again, just getting the discount more aligned with patient and patient access. The majority of 340B hospitals actually provide less charity care than non-340B hospitals, and there's actually increasing work in this area as well. The other component of it is that HRSA allows contract pharmacy arrangements with grantees and with hospitals. And so this is another question that we have as if patients see benefit from this. Originally, the kind of vision was that grantees wanted to participate, but they may not have a pharmacy on site. And so then they made an arrangement with an outside pharmacy to be able to capture the benefit of the program, feed it back into the clinic. But what we've actually seen is that hospitals have, generated significant arrangements with retail pharmacies, CVS and Walgreens, like the big name pharmacies that we all know. And patients don't necessarily know. They could go to the pharmacy counter. They could have gotten a script from a 340B covered entity. They could pay almost all the cost of the medicine because their plan doesn't cover, the cost. They have a significant deductible or coinsurance. But then this is a 340B prescription that on the back end, the retail pharmacy is capturing money from, and then the spread is going back to the hospital. So again, there are just kind of questions about the way that the program is aligned. And as we've seen uninsurance drop, now the uninsured rate doesn't necessarily correlate with access, as we've all talked about. However, we've seen a drop in the rate of uninsurance, but participation in 340B retail pharmacy program has grown, and you can see those lines are heading in different directions. And the program is growing. It was a very small federal program in 1992, but it's a significant amount of pharmaceutical sales. There was actually a article that came out a couple of weeks ago, a study by an academic. Almost half of all drugs that are sold on an outpatient basis through hospitals are purchased at 340B prices. So this is an area that is having a significant impact on the market for medicines broadly, and it's a growing program. And so we appreciate the opportunity to talk about it and think about ways that the program could be reformed so that it's sustainable and that it's aligned with making sure that patients have access.
Thank you, Dr. Ybarra. Our final presentation will be given by Aaron Vandervelde, who's the Managing Director for Berkeley Research Group in Washington, D.C. Mr. Vandervelde.
Great. Thank you all for having me here today. And I'm going to build a little bit on the comments from Mike. And I suspect the group is wondering, how does 340B really impact me as a practicing physician? And it's a legitimate question, and one that hopefully some of these numbers will help answer for you. I'm going to skip through this slide pretty quickly. The one thing that I want to note is that the 340B price is a statutory price, and it's really a component of the Medicaid program, and that price is typically between 30% and 50% of sort of the average price that's available in the marketplace. So I want you to sort of keep that metric in your mind, the fact that the cost of the drug to 340B covered entities is typically 30% to 50% less than the cost of the drug to everybody else in the marketplace, probably many of you included. We talked a little bit about the growth in the program. Mike showed a metric of how many hospitals are now participating in the program. This slide sort of puts the overall program into a bit broader context. So there are quite a few different types of covered entities that participate in the program. And when the program was first launched back in 1992, there were only about 90 or so hospitals. By 2004, there were several hundred hospitals that participated in the program, I think about 200 or so, and there were literally almost 10,000 other types of entities that were out there. In 2004, there were a total of about $2.4 billion in drug purchases that went through this program. So fast forward about 10 years, and you now have 2,000 hospitals that are participating in the program. About the same number of all other types of covered entities. The program is now driving about $8 billion in purchases. So you can see how the participation the growth and participation of hospitals has really driven growth in purchases of 340B drugs. And you can see it very well here. This was research that was done both in 2004 and then again in 2011, 12, and 13, looking at what types of covered entities purchased 340B drugs. In 2004, you had less than half of all purchases were going through hospitals. By 2011, 2012, that number had grown to almost 90%. So the 340B program today is really driven by hospitals. So the question is, well, why does that matter for you? Those hospitals in many marketplaces, and oncology is a marketplace that I personally have studied a lot, those hospitals participate in a broader marketplace for oncology services. When that healthcare service involves the administration or the prescribing of medications, there is a significant difference in the cost equation, and so subsequently in the profitability. If you have a player in the market that has access to a price that's 30 to 50% lower than the price that's available to all other participants in the market, that's a significant advantage. And the way that that's played out, and again, we've really studied this in the oncology place, in the marketplace, but we believe it exists elsewhere, is that competitive advantage leads to consolidation. This is the idea that hospitals are acquiring community oncology practices, bringing those practices into the hospital, and when that occurs, the hospitals are now able to purchase the drugs that were historically prescribed by the community physician. They're now able to purchase those drugs through the 340B program and realize that spread that Mike was talking about. We've looked at the extent to which that's driving growth in the program, and I want to fast forward to some of the modeling that we've done. We think that the idea of hospitals acquiring community practices is going to be a major driver of growth in the 340B program. I mentioned that $8 billion number for 2014 sales. We see the program growing to almost $16 billion in sales, a little over $16 billion in sales by 2019. And we think one of the biggest drivers behind the contract pharmacy construct that Mike was talking about is going to be acquisitions of community practices. So in the different groups that I've spoken with over the past couple of years, medical groups like NMA, this is of particular interest because there are obviously many physicians that want to continue to maintain their private practice, but it's very hard to do that when you operate in a marketplace that has this type of distortion. So I know it's basically me and lunch or the Q&A at any rate. So I wanted to keep this really short and give you a perspective of the numbers, but also give the group a chance for questions for the whole panel. So happy to have follow-up as needed.
Thank you, Mr. Vanderbilt. I know that there are a lot of questions. Let me just mention that we're at lunchtime, and we're only going to take 5 minutes. We're doing very well on our time schedule. So when you ask your question, make your question brief. Don't make any declaratory statements, anything of that sort. Please keep it under control.
Two questions, sorry. One question.
Introduce yourself first.
I'm sorry.
Quickly.
Virginia Kane, I'm director of the Marion County Public Health Department. Work at the fourth largest public health hospital. We do 340B pricing. But Mr. Barr, one of the concerns I have at a public health hospital is we have a lot of our solo physicians in private practice, African Americans, and we may have patients that got an A1C of 13 and 12, and I bring that down to 9, and yet someone who's, let's say my white counterpart, living in the suburbia, most of the average salaries of the patients they have is $75,000. So when they see a diabetic, their A1Cs may be 7. They bring it down to 6.5. But he gets a better report card than me. because I've done more remarkable things, bringing that A1C down from 13 to 9 than he's brought from that 7 down to 6.5. But when they do a report card on me, I look bad. So how are you addressing those type of performance standards?
Excellent question. I think I referenced it kind of tangentially in the Global Cardiovascular Risk Score. Let me explain that a little bit. It's something we're working with. It's basically all those biometric data, the cholesterol, hemoglobin A1C, all those things go in, and then you get a score. And you're judged not on the absolute value that you change, but improvement in the score overall for that particular person, and then that rolls up to the population that you're serving. It's a great issue, and it's something that definitely needs to be addressed. The current measurement set, as I said, that's why I led with that, needs to be improved and changed to get to those kinds of issues. There's a larger issue in terms of when you look at our health plan ratings, where the health plans who have patients and populations that are also disadvantaged, they say their scores are not as good as those who have a different kind of population, and therefore there's a call for adjusting the measures and eliminating the visible disparities. Because they want to get paid differently. What we want to say is we shouldn't eliminate the disparities, we should pay differently and reward for improvement, not just absolute thresholds.
Very good. Before we go on to the next questioner, I want to solicit a comment from Dr. Riley. Remember I mentioned that I was going to ask you about P4P, and I wondered if you could weigh in on that.
Sure. Mike touched on this a little bit, but again, this is one of the areas that we at the ACP have really looked at very closely. Performance measurement, as I think you clearly understand, is here to stay. Now, with regard to physician reimbursement issues, that's where, we all work very hard, and I know many NMA presidents back 20 years did similarly, trooped up to Capitol Hill every year to try to get the SGR fixed. And I'm delighted that I'm the first ACP president that didn't have to do that because we got it fixed. But with that, colleagues, came this move to value-based payment schemes, either alternative payment or the other. And so this newer iteration of P4P, I would argue, is a lot more user-friendly than sort of the initial P4P approach that many of you have been exposed to. So I think it's better. Is it still going to be hard, tough work? Yes. But I believe it's a better way to get to performance measurement at the same time to reform physician reimbursement.
Performance measure, big issue. Gentleman in the back, could you introduce yourself, and is there a microphone close to him?
I can speak loud enough.
Okay.
I wanted to quickly, with precision medicine, what do we know about the diversity of our genomic testing? Because my concern is that they're going to make precision medicines that are only going to be to the larger genomes that they know are, that they have in their database. And that may exclude people like us.
Absolutely. How many of you have done 23andMe, the genetic test? That's the problem, just right there. We only had, 5 or so? And Dr. Bright just hit the nail on the head in terms of what I worry about in precision medicine is that the database will not be robust enough to include the patients you take care of. If even of those of us in the highest tax bracket in the country, only 5 or 6 of us in this room have ever done 23andMe, that tells you the challenge we have in terms of getting everybody's genomic information into various databases.
So is that something that you would advocate for the NMA to get behind?
Well, I'm not endorsing a commercial product, but I do
the whole thing of
I do
genomic
plead
testing.
with the NMA to put precision medicine on your radar because it is here to stay, and there's massive federal investment, by our great President of the United States in this. But the devil's in the details in terms of the work that you do on a daily basis in the communities you serve.
I'd just like to add to that. We're actually, we talked earlier with Dr. Doug Lowy from the National Cancer Institute, and he and I are working on a project, and we're working with 2 of the most prominent companies in this area. So I'm hoping to have something to announce in the near future. We can take one more question, and then we got to go to lunch.
Even though the sign back there says for us to stop. One more question. Dr. Butcher,
Okay, I have two quick points.
make only one. Combine them.
The one is on the vaccines that we get and coming to the offices. Is that included in the 304B?
They're not. No, they are not included in the program.
So Vaccine for Children provides free vaccine for providers out there for a discount because we can't afford.
That's right. The three.
Why can't 340B do the same thing?
Good
It makes
question.
a level playing field for
Very good.
providers.
Great
Very good
question.
question.
One quick answer?
The 340B program does not include vaccines.
Okay.
And the final thing to the pharmacy individuals who spoke, we're just being flooded with all of the companies saying, you got this free medicine for a year and all like this, and they encourage us to sign our patients up on this, but that's just so that they can put it into the various programs and so forth, and it really is inundating, and I don't know if that's the new nature of how things are going to be done, especially like all these diabetic products. If you sign them up and you can put them on, we'll give the free for a year, but you need to put the patients on it.
So any questions or answers will be taken care of outside the room. So it is time for lunch, and there are a couple of announcements. First off, no, we don't have time to do that. We have just a few announcements.